Hello, in today's lesson, we are going to talk about the mammography exam, content specification. I'm going to give you all of the information that you need to know to pass your registry. And this is going to be for the registry review for mammography. I do have several material Q&A videos, lessons in my mammography registry review playlist. So if you're wondering how many questions will be on the test, I have it broken down right here. For patient care, there will be 20 questions. For image production, there will be 30 questions. For procedures, there will be 65 questions. The total number of questions on the registry is 115. So to be honest with you, this really isn't a lot. So it's not a lot of room to miss a question. And I say 115 is not a lot because when I had to take X-ray, CT, MRI, and breast ultrasound, because I am registered in 5 modalities, my other exams had 200 to 220 questions. So 115 is not a lot, so you really need to know the information. And you also have those 30 unscored pilot questions, which is those questions that they throw in that it's not scored, but they're trying to see if they can add it or need to add it for the next set of questions, how many people will get it right, how many people will get it wrong. And then altogether, there will be 145 questions to look forward to. So some tips that I have is you must know every category, especially patient care. Patient care is one of those things where people, oh, I know patient care, I do great on it, and they do not study. But if you don't study patient care, it can actually be the hardest category on your exam. And then I will say focus more on the category that you are most unfamiliar with or weaker in. So if you know that you're not good in physics, spend more time on focusing on physics first, and then focus on procedures and patient care. So, whatever you are not good in, focus on that first and focus on it the most. I do have special shout outs. These ladies use my mammography registry videos. They clicked on the playlist, they went through the playlist, and they just started watching all of the videos that I had. So these ladies passed their registry in this month, July 2025. So shout out to these ladies. I do have a couple of more that I will shout out at the end of the video. So if you are using my videos and you pass your registry, could you please just come back to one of my mammo videos and just like write a message like they wrote, just let me know that you passed your registry, and then I can just add you to the shout out board as well. I think this motivates and encourages people to, watch the videos because they know, oh, other people watch your videos and they pass as well. So I'm just trying to get as many people to pass their registry on the first try. So if you don't mind, just leave a comment and I can put you on the next video that I make. Okay, so here are the breakdown. We'll start with patient care. For patient care, there will be 20 questions and it will talk about patient interactions and management. So for this section, not only is this helpful for your registry, this section is also helpful for whenever you work as a technologist because this determines how the patient results will come out, how they will be diagnosed. So you want to make sure that you are communicating with your patients, especially about the importance of removing deodorant and clothing. So a lot of times patients are saying, the deodorant that I have on, it doesn't have aluminum in it. It's clear. It's not this kind. It's not that kind. I still get patients to remove any deodorant that they have on. To be honest with you, I don't have the extra time to step away from them and Google on the internet if this kind is safe for mammograms, if this kind will show up or not. All I know is deodorant cannot be used. So I'm going to offer them the deodorant removal wipe and just tell them, hey, could you just please get it off? I'm not sure if it will show up or not, but this will prevent you from being called back. It also prevents them from having a biopsy being performed unnecessarily. So let's just say if the patient told you their deodorant is good and you do not leave any notes in their chart stating patient refuses to remove deodorant, now the radiologist is going to notice the deodorant and think that it's calcifications under their axilla or on their breast and call them back. Worst case scenario, what if they get a biopsy performed on that area? So now it prevents the results, it increases anxiety and fears. So just have the patient remove the deodorant. They may argue with you, but just let them know it may show up and they will probably have to be called back. Also, have them remove their shirt and bra because sometimes the robes that we use, it can show up on the image as an artifact. Also, you want to explain the time frame to the patient, such as tell them it's going to take 5 to 10 minutes to do this. Rehearse breath holds with them, especially if it's their first mammogram. You're going to have to explain a lot to them. So you're going to have to let them know when they have to hold their breath, how long they will probably have to hold their breath for, demonstrate the different positions that they may be in, because this is just important for them. They're already nervous about the first mammogram. So you have to be very thorough with your baseline patients. Also, whenever you are giving the patient their results, they may ask you, especially if they are, let's say, 60, approaching 70, or if they have family members who are older, they are probably going to ask you when should they stop getting mammograms. I've I've had this happen to me numbers of times. I can't even count. It's been over hundreds of times where a patient will ask me, when can I stop getting mammograms? I always tell patients that because there are several organizations, you do not know which one they are following. So I just go by which one my organization follows, and I just let them know as long as you're in good health and expect to live longer than 10 years or more, they want you to keep coming in for your mammograms. But there are also other organizations and guidelines you have, and this is what you need to know for your registry. You need to know the difference between these organizations and their guidelines. And you can also find the breakdown in my patient care video that's like an hour long, but you can watch it in pieces. You can find this information um in like the Q&A videos that I've already done where I quiz you on this. So for the American Cancer Society, you have to know their guidelines, organizations, such as when patients come in, when they do not have to. You need to know the American College of Radiology, U.S. Preventive Services Task Force. So know which organization recommends and do not recommend mammograms and what age they recommend that they start or the patient should start. All right, so most patients they will have their mammogram done by age 40. And this is the guideline that my company follow. The annual mammograms will start at age 40 and it will continue afterwards as long as they are in good health or expected to live 10 years or longer. But there are some patients who come in before age 40, especially if they have like a first degree relative or family history of breast cancer. And then also if a patient feels like a lump, they will come in before age 40, but that would be under diagnostic if they feel a lump. Okay, so we have the U.S. Preventive Services Task Force that I was telling you all about. They recommend individual screening mammograms based on the risk of the patient/individual. So it is recommended against having this done. So screening mammograms begins for patients between age 50 to 74 years old for this organization. No screening mammograms are done after age 74. So starting at age 75, the patient, they do not recommend mammograms. And then for breast self-examinations and clinical breast self-examinations, they do not recommend. Also know that breast self-examinations are done by the actual patient or person. The clinical breast self-examinations or the clinical breast examinations are done by the healthcare provider, like your OBGYN, who is the person who normally does my clinical breast examinations when I go in for a pap smear. Can you all put in the comment box if you've had this done? I'm sure by now you all have had like a pap smear done. So just let me know if your doctor is doing, or OBGYN, or doing the clinical breast examinations on you. And also, I know some facilities, they require the mammotechs to do the self-examinations on patients. I know the facility I work for, they no longer do them. I think someone was saying, like, due to COVID or something, whenever you have to do the distancing, that's when they stopped, and I guess they just haven't picked it back up. So just let me know in the comment box if your facility is doing these self-examinations on patients before you start the mammogram. Now we have the American College of Obstetricians and Gynecologists. The screening mammograms are done every 1 or 2 years, or once a patient reaches age 40 to 49 years old and afterwards. So this is for this organization. Now we are going to talk about the American Cancer Society. And this is why I always tell patients to check with their doctor on what their doctor recommends, because as you can see, there are several organizations and guidelines, and you just do not know which one their doctor is, going by. So annual screening mammograms and clinical breast examinations performed annually based off it being the patient's wish to have one. So this is what ACS follows and recommends. Mammograms are also recommended every year for women ages 45 to 54 years old. Breast examination for breast cancer is not recommended for women at any age. Continue screening mammograms as long as the woman is in good health and expected to live 10 years or more. A screening breast MRI and a screening breast ultrasound for women at high risk for breast cancer or with very dense breast tissue. I do work in MRI as well, so I perform the breast MRIs a lot. You will see it right above me. That's a breast MRI image, and then you also know that's your mammogram image at the very top. A mammogram is done every 1 or 2 years for women between age 55 years and older. Breast self-examinations and clinical breast examination are not recommended. And the reason why they aren't recommending the breast self-examinations or clinical breast examination, that's because patients may think they're feeling a lump and they become extremely anxious, and it causes more fear and anxiety. So that's why they are not, or that's probably why one of the reasons why they are not recommending it. Okay, now we have your 2D versus 3D mammograms, because patients are going to ask you which one is better, which one should they get. So overall, a 3D is better for patients with a stronger family history of breast cancer, disc breast tissue, personal history of breast cancer, etc. But overall, a 3D is better, and that is what the patient should be getting. 3D mammograms reduces the patient from being called back, because it allows the radiologist to have more images to see through their breast tissue, especially if it's dense breast tissue. A 2D mammogram is one image, and patients may get called back if they have dense breast tissue, but there are times where patients just cannot get the 3D mammogram. Although most health insurance companies are covering 3D mammograms, but there are times where their insurance just do not cover it. Like recently, I'm not sure if this was a Medicare patient or not, but the mammogram just could not be changed. And then when we looked at the patient's prior history, they had been getting they had been getting 2D mammograms all along. So sometimes with Medicare they can have 3D mammograms, but sometimes if it was like accidentally ordered that way, you cannot change the Medicare patient's order. You have to reach out to Medicare or to like their doctor to get them to change it to a 3D um, mammogram. So I'm not saying Medicare does not cover 3D mammograms. I'm just saying if it was accidentally put in incorrectly, you have to reach out to Medicare or their doctor before you can change it, because for some people you can just go ahead and change it to a 3D mammogram. If they say yes, I'll just go ahead and get it. But for some insurance companies, it has to be changed by them. Okay, so you do have to know your patient radiation dose. I like go into further details regarding the physics in my physics video that's an hour long, but it is time stamped. So it's time stamped on which topic I'm talking about. Um, you can also pause the video and just go back and watch it later. But the American College of Radiology, or ACR, they recommend that the mammogram image or projection should not exceed greater than 3 mgy or zero point 0.3 rad or 300 millirad with a grid. And then it should not exceed 1 mgy without a grid. So make sure you know these numbers. These numbers are also in relation to the average glandular dose. If you do not mind, this is something I just like to do. Could you leave me a comment? Just let me know what state you are watching from. I think this is just cool to do because you get to see how many people over the world or country, you can put your country as well, is learning mammo, is about to work in mammo. You also get to see like which states have job opportunities to be a mammo tech. So I have people watching from California, Houston, Florida, Maryland, Arizona. Um, I think I said California because a lot of people's watching from California as well. So, Atlanta, Georgia is watching. So just if you made it this far in the video, leave a comment, just say I'm watching from, and you can say your state or country's name. Okay, now we have our breast cancer risk factors. For your major risk factors, female gender is the number one greatest risk factor. I'll say it again. Female gender is the number one greatest risk factor. And then you also have genetic risk factors whenever patients are positive for the BRCA1, BRCA2 gene, then you have your check gene. You have Asian, dense breast tissue, family history of breast cancer, personal history of breast cancer, or personal history of cancer in general. For your minor risk factors, you have alcohol consumption, never giving birth to a child, never have breastfed, having your first child after age 30, late menopause, early menstrual cycle, using hormone replacement therapy, weight gain, and smoking. Now we have our signs and symptoms. These are important for you to know. So, does the patient feel a hard lump that is fixed, meaning it doesn't move, it's just there? Inverted nipples. Do they have nipple discharge? There are specific colors. So, of course, if it's red, this is going to raise an alarm for them to be called back for a diagnostic. Well, they should be a diagnostic in general if they have red nipple discharge, but more imaging is going to be done, probably a biopsy if something is found. And then you have pain. So, is this related to their hormones, caffeine intake? Are they stressed? Do they need a new bra? Is it focal pain, meaning if it's in one area? So these are like the signs and the symptoms that you all have to know. Once again, this will be found in the patient care video I will try to remember to link it at the end of the video so you can just click on the screen and just go to that, because in that video I give you all of the information that you pretty much need as well. Are there changes to the skin, such as thickening, redness, or skin dimpling? Does the patient have eczema, or is it Paget's disease? Now, for the surgical and biopsy history, it is important to document and verify all of the patient's breast surgical and breast biopsy history, because if a patient has a scar, then the doctor will, or the radiologist will, correlate it to breast reduction surgery or breast enhancement surgery, such as your breast lifts, or they can correlate it to breast implants. And then you also want to make sure that you are placing your mole markers and scar markers on the patient's breast to avoid callback. Document those tattoos. I do have a video. Go to check out the playlist. I have a video where I tell you all the proper way of documenting. So check out that video. It's extremely helpful. I would put it at the end of the video for you to click on, but it's a certain amount of videos that they let me attach at the end so that you can click on. I think the max is 2. And so if you go to my description box, I will put in the description box the playlist so you can just go there and click on it if you don't know how to find it on my YouTube page. So also document if the patient has had a mastectomy or a lumpectomy. This is just so the mammotech and the radiologist can know, especially if they see like a biopsy clip, to know, hey, this patient have already had this site looked at. So before you take any image on a patient or perform a biopsy, I always want to make sure that you have the correct patient. Even if you work at a place and someone is rooming your patients for you, always make sure that you know that you have your correct patient. Even if the patient get upset and say, this person just asked me my name, what if someone put the wrong patient in your room? Or what if the patient that you call, another patient have the same last name or the same first name? So you just never know. So always check the name, date of birth, and check their order as well, because you can match the order and the name and the date of birth to the MRN number, especially what's on your equipment. So even if you have the correct patient, you still have to have the correct patient name pulled up. So that's another thing. Also, when you're verifying that you have the correct order, sometimes 2D orders are mistakenly ordered. A patient want a 3D order, but they probably self-scheduled themselves and put in a 2D order. Or maybe the doctor or the nurse put the order in incorrectly, or whoever normally put the order in, maybe it was put in incorrectly. Also, check with the patient before you just automatically change their order to a 3D mammogram. Sometimes a patient just do not want a 3D mammogram, even though it's better. They may think, oh, it's more radiation, because patients, they Google and they read stuff before they have their mammogram. So what if they read on the internet, this is more radiation, I don't want it, so they have the right to refuse it. And if a patient has a new lump, we all know a screening mammogram cannot be done. This has to be done under a diagnostic mammogram. Explain the exam to the patient. Just do not assume that they know how it's going to go, because like patients come in, they always say, I'm never going to get this down, because we all do it differently. The way I do my mammogram is I start with the right side. I start with the right CC, and then I move to the right MLO, and then I move to the left MLO, and then I do the left CC last. So someone else may do it in a different order. Also, explain the biopsy procedure. If you normally participate in biopsy procedures, consent the patient, take down their allergy history to medication or to latex. Go over the recovery process with them. So let me know in the comment box if y'all have any questions. You have your fall risk patients. Perform the mammogram in a wheelchair if the patient arrives in a wheelchair. We all know it can be tough performing mammograms in a wheelchair. You may get a limited study. So document limited study, but get the best images as possible, because if you don't, the patient will have to come back. So that's why it is important to check those prior imaging, because you get to see what the tech last year got. There's been times where you can get more than what the tech got last year, or you may get less than what the tech got last year because of the patient's condition. Maybe it has changed, maybe it has increased. And we know that getting a mammogram image standing upright is the best, but you don't want to jeopardize your patient's safety and increase your patient risk of falling. So go grab another tech if another tech is not available because you're working by yourself, or for whatever reason you just have to do it by yourself. Have the patient, and I made a video about this as well, on how to position special patients. It's in my playlist, but for your wheelchair patients, have them sit upright. Um, Lean them closer with a pillow or a wedge behind their back. A lot of techs have found that the stereotactic machine, or sorry, chair, which is above, they get great images when patients sit in there in that chair as well. If they are being done in a wheelchair, remove the armrest and the foot pedals out of your way. That helps get the patient to lean in, especially for the MLO views. So this is just a summary of what I found on the ARRT website on what else you have to know. So just review this information. You can pause the video. I did cover a lot of this in that 1 hour video that I was telling you all about. So you can find this information in that video. Whenever you are going through my videos, if there is something that you have not found, you can leave a comment and ask me to make a video about that topic. All right, so now we're going to talk about image production, which will have 30 questions. It's going to cover image acquisition and quality assurance. So physics, which is going to be the largest part of the exam, actually it's the second largest part because anatomy is the largest part of this exam. But make sure that you know your common target material that is used in mammo, which is tungsten, molybdenum, and rhodium. Also know the different KVP ranges. We do have AEC, which is going to automatically adjust. So you still have to know the ranges, but whenever you are working in mammography, you do not necessarily have to find or select your own KVP range, because AEC will like automatically adjust it according to the patient's breast thickness and size. But you do need to know, because worst case scenario, what if AEC have failed that day and it's not working properly? I do see, not all the time, but when I was trained, there was someone who was training me who adjusted their KVP based off implant patients. So you do need to know your KVP ranges. Know the benefits and the disadvantages of using grids. Does it increase radiation when you use it, or does it not whenever you are using grids? That can be found in the physics video that I've made, which is an hour long, where I cover all of this information. But if you do not see it in that video, comment and let me know which new video you would like for me to make. Also, your compression paddle, we have different sizes. Know the different size. Know the compression pound initial um, limit, and know the limit that you cannot go above. Also, your monitors that we use in mammography. Know which kind of monitors that we use for techs and for radiologists, their screen, which is different. That's why the radiologists are able to see little motion compared to us. So whenever we're taking the images, we're thinking that it's clear. And then when they come across to the radiology desk, they may call the patient back for a technical repeat due to motion that they found. And then you also have your QC, your QA, and the person that performs it. So for your QC and your QA, um, which QA is performed by this person or that person, know that the mammotechs perform these type of QCs and versus the medical physicists perform this, and how often it is performed. Is it performed weekly, annually, semi-annually? I do have a video that I've already done on MQSA and EQUIP, but just know what it's about, what they implemented. um, MQSA is pretty much to make sure that Mammotechs is performing those mammograms correctly. We're just not, throwing the patient breast on the board and just taking an x-ray and just stepping away. We are actually getting the proper anatomy, proper amount of tissue, positioning the patient correctly. Equip is going to correct these problems if there are a lot of problems or mistakes occurring where the images aren't coming out correctly. Equip has ways on how it can be fixed. So just go to the playlist and you can read up about these videos, because I have when the law was put in place and who regulates it. Also know for your license renewal and requirements for Mammotechs, how many CEUs is needed. So we need 15 CEUs every 3 years, 200 exams to be done within 2 years. You also have educational requirements. You have where you need 8 hours of digital breast tomosynthesis training. Also for your initial, how many exams you need, how many education credits you need for your initial. So all of this is important for you to know whenever you are preparing for your test, which can be found in my physics video that I told you about. Know the difference between spatial resolution and contrast resolution. These terms are confusing for most techs. You can put in the comment box if you always have if you're confused about these two terms, but know the difference between those terms. What is the definition for mass and KVP? Why is it used? What does each one control? Does it control contrast? Does it control brightness? Small focus spot versus large focus spot. There are numbers that goes with this. So once again, check out the physics video. I say that because I've already pretty much answered a lot of these questions in that physics video. So that's why I want you all to go to that and check it out. Know your signal to noise ratio and contrast to noise ratio definition. Down here, the picture that is beside me, that's the picture from the QA. So know which one is your fibers, which one is your specs, which one is your mass. And then this is pretty much what I just went over. Everything that you need to know from your test. I got this from the ARRT website. So for your questions, you need to know the purpose, how often it is performed, what actions you can take to correct this. Um, it goes over your ACR, your FDA. So this is important information. I would just use this, and then when you go to my video, if you do not see any of this, let me know and I can make a separate video. But I have all of this, and I have Q&A questions and answers for you as well to test your knowledge. And then this is more information that you have to know. Your grids, magnification, labeling. You should know what is going to be on the final image. You have your facility name, you have the patient's name, date of birth, MRN number, the date that it was performed, the time, the technologist's name or initials will be on there. You will not find the patient's address or social security number on the final image. Also know artifacts. How does it look? What happens whenever you have to, if you see an artifact? When we found an artifact on one of the images at my facility, the room was pretty much shut down until the service engineer or medical physicist came out and corrected it. Because if you are seeing artifact in the breast, a lot of those patients will have to come back just to make sure that is it an artifact or is it an actual mass or tumor or abnormality in the patient's breast. All right, so now we are going to cover procedures. This is the largest section of the test because this is 65 questions. So we'll talk about anatomy, positioning, procedures, tumors that will be found under the procedures. Know your clock position of the breast, 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. If you were to be asked, um, such as if a abnormality was found on the left breast at 3 o'clock, you know, do you know how to know, okay, if a mass was found at 12 o'clock on this side of the breast, what quadrant is it? Is it 12 o'clock? Is it 3 o'clock? You know, if it's upper outer quadrant, lower inner quadrant. These are things that you need to know. Also, this is very helpful, especially if you are working in the diagnostic section for the day. Whenever a patient is called back on the report, it will let you know which area they're being called back for, where the radiologist may say 12 o'clock, 7 centimeters from the nipple, um, upper outer quadrant, 9 o'clock, 6 o'clock. So this picture will help you determine, okay, which area is 7 o'clock where I have to do my spot images. So you can pause this video and just know your clock positions. Also know your quadrants, which one is considered upper outer quadrant, your lower outer quadrant. And then, like I was saying, for your test, if you're asked on the right breast, I'm just throwing out examples. On the right breast at 2 o'clock, is this your upper outer quadrant, your lower outer quadrant? So you have to know that. And if you need me to do more review questions and answers, just let me know. But I do have under my anatomy video where I go into like certain examples. But if you need me to do more after watching those videos, just let me know. Know your anatomy. This is extremely important. Know your anatomy. Know how to label this picture if it was not labeled. Something you can do is you can just rewash this. You can cover it up with a sticky note and try to guess which one is which. I probably could do a separate video like quizzing you all as well. Just let me know if you need me to or not. Um, but know your anatomy. And I also have anatomy video for this as well. I have so many videos for you all. A lot of people who have already passed their tests like in May and June. They did not have half of these videos that I have for you all, but they still passed with the videos that I had. I think a lot of the videos they watch was those 1 hour videos as well. So I will say that you all have a lot more videos. So that's why I'm like, just check out the playlist because I'm sure you probably already have a lot of videos made already. But if I don't, you can comment and I can make more. Okay, more anatomy for you to review. Just make sure that you are knowing. If you was asked to identify where the pectoralis muscle is at, do you know how to identify it on the mammogram? Do you know how to identify the IMF, the chest wall, uh, the nipple, things like that? Do you know the difference between fatty tissue and dense tissue? These are your margins, which is important to know. And I covered this in my last anatomy video. Which one is benign? Hopefully you know that if you see circumscribed, that's pretty much most of the time benign. Your spiculated margins will raise concern for malignancy. So Most of the time, spiculated borders are cancer or will turn into cancer. These are the benign pathology that you have to know. So know the definition. You can also know what age group these categories fall for. Like for fibroadenomas, you'll normally see these in younger patients, especially if they are in their 20s. I've had someone told me that they had a fibroadenoma when they was like 17 or 18. For your cysts, know what age range you'll see these: 30s, 45, 40s, any age, but most commonly which age you will see this. And then you have your lipomas, hamartomas, papillomas, hematomas, edema, seroma. Why is edema and seroma occurring? Is it from trauma? Is it from surgery, abscess, and inflammation? So these are important terms for you to know, which I have in my 1 hour anatomy video. I list the definition, go over the age group. I already have a video about this. Okay, your malignant pathology that you must know: ductal carcinoma in situ, your IDC, invasive lobular carcinoma, sarcoma, lymphoma, Paget's disease. I did a Q&A video on this already. Um, it may be titled Anatomy Q&A Part 1, Part 2, Part 3. So that's how you can find those. It's like a Q&A where I quiz your knowledge on the differences between this. Also, you have the benign tumors with an upgrade of potential pathology, which is your lobular carcinoma in situ, a typical ductal hyperplasia. So whenever patients have this, it raised suspicions for them possibly getting breast cancer in the future. Your phyllodes tumor, which resembles a fibroadenoma, and with your phyllodes tumor, that increases in size like within weeks. Your radial scar, your papilloma with atypia. So these are all the things that you need to know the terms for. Positioning views and procedures. For your CC view, know that this is the best view for your medial tissue. Your MLO view is better for the outer, quadrants. Your lateral 90-degree 90-degree views is especially done whenever someone is coming back for a diagnostic workup. And then know which tube angle you need for large body habitus patients. I always say try not to automatically fit patient's body in a 45-degree angle, even if they're kyphotic. For large body habitus patients, you may have to decrease the tube angle to 40 if they cannot position themselves correctly in 45. For kyphotic patients and wheelchair patients, you will have to change the tube angle depending on how they're able to tolerate. So for kyphotic patients, I normally find it best to angle the tube anywhere from 50 to 55 degree, especially if they have pectus excavatum, where they have bird chest or the sternum is sticking out. For wheelchair patients, you can get some good images if the patient is at 40 degrees. You can also get some good images if they're at 45 degrees. Also, we have special modality procedures: breast MRI, breast MRI biopsy. So for breast MRI, the gadolinium contrast will be used. So make sure that you know that and know why a breast ultrasound and a breast ultrasound biopsy is ordered. So breast ultrasound patients will not get that done if they have calcification. So specifically, if a patient is coming back for calcs, they will not go to breast ultrasound, but the doctor will just, put it in just in case something else was found. Then sometimes they do not know breast ultrasound is not ideal for calcs. And then you have your stereotactic. Why is this ordered? For microcalcifications. And then you have your localization procedures, your LOCs for your non-palpable patients. All right, so this is all you need to know for the procedures, positioning. The ARRT did a great job at letting you all know what you have to know, what's important, what to expect on your test. So you can pause the video, you can study this. I did follow this content outline in the 1 hour video that I made. That's why it's so long, because I made sure that I covered this information. All right, so now I'm going to get into some tips and tricks on how you can study for your exam, prepare the fees, the exam prep, what to expect on your test day, and your results. Okay, so the Mammography Registry exam will cost about $225. This is for the year of 2025. You must have met all of your clinical requirements. You must have met 16 hours of continuing education credits if you did a self-study course. If you went through a college, you don't have to worry about this because the college have already prepared you with the credit hours. I did a self-study course, so I had to go to ARRT website, find this information that I have above, and I had to make sure that the self-study course that I took followed this information and gave me at least 16 hours of credit hours. I always say do not reschedule your exam, no matter what. I always had techs who told me that when they reschedule, they end up failing. It's just by luck, I guess, not always, but a lot of techs told me that when they reschedule, they fail. So I always say just don't reschedule your exam. I think this increases anxiety and just make you more nervous when you reschedule. So I will let you all know what I did to pass. I did not go through a college. I did a self-study course online. So I study from at least two review books. I always keep at least two review books, sometimes more. I read the entire books front to back for about 5 to 10 times or until I was able to understand the information fully. I reviewed the review questions, the answers, and the explanations that was in the book and online. So I always say review the explanations as well, because when we're being asked a certain question, most people just focus on the answer, but the explanations give you more of what you need to know. It tells you why the answer is correct and why it is incorrect. So I did study over 3,000 review questions and answers. I wanted to make sure that I was well prepared. I wanted to make sure if a question was asked this way, I would know it. If I studied another question that was asked that way, it will be easy for me to answer it on the registry. Two books and multiple review questions and answers will increase your chance of knowing the questions no matter which way it is asked on your registry. I do not recommend going longer than 3 months because you will forget some of the information. A lot of people ask me this, but I tell you all, unfortunately, I cannot recommend a good book. In the past, people had suggested books and websites to me, and it did not help. I still passed my registry, but I wasted money, I wasted time. The information was not similar or even close to being what was on the registry. So it didn't help me at all. Lastly, I do not want anyone saying that I suggested the wrong book. And I do have several review lessons, questions and answers, and anatomy to help you prepare after you have gone through your educational program. And I also have those 1 hour videos, which you can use as like your seminar or your webinar, because it's 1 hour long and it's just pretty much reviewing all that you should have learned in your program and just refreshing what you need to know. So make sure that you're breaking down the material in like bite-sized pieces. Try not to just remember it all in one sitting. You're just going to have to take it like one step at a time, one day at a time. Like I was saying at the beginning, if you know that you're weak in physics, then study physics first. If you're weak in anatomy, study anatomy first. If you know your patient care, still study it, but study it last. So, physics and sectional anatomy is the largest part of the exam. Don't forget patient care. I always study that as well. I always say patient care can be the easiest, but it can be the hardest at the same time if you do not study. Do not forget to do this before your test date. Do not study no more than 3 months. Do not reschedule your exam. I know some people that reschedule their exam and they fail because of anxiety. Do not tell everyone when you are taking your test. This will make you more nervous and stressed to pass. So no one wants to hear about you failing. So um, just take your test. Do not tell anyone that you're taking it. Um, because people, believe it or not, people are like sitting by the phone. I had worked at one place in MRI, and they unfortunately they was like, I don't think this girl is gonna pass, or I don't think this guy's gonna pass. So they're sitting waiting by the phone, waiting to see, are they gonna pass? Let's see. So I don't know. I just don't like to tell people what I'm doing because I don't know. I just feel like, what if someone is hoping that you don't fail? I mean, that you don't pass. And then you have people who is just rooting for you to pass because they're excited for you. They want you to start working. They're excited that you're in a new modality. So you just never know. Do not study, only review questions and answers. Make sure to study the textbook material as well. So, yeah, just don't focus on the Q&A. You can focus on it, but focus on it after you know the lesson. Do not study the night before your test. You should know the information. Reviewing your notes is fine, but just do not study to know it the night before your test. These are things that you do want to do before your test date. You want to get a good night rest, have all required documents and test form with you because you will need like a proof of identification. So I always just play it safe, and I always bring like my social security card, I bring my license, and I even bring a debit card because on your debit card, for most debit card, not all, but one debit card or credit card that I have, I had to sign my name. So I was just bring, I don't know, 3 forms of ID. Make sure that you set your alarm clock and arrive early. Make sure that you have reviewed everything before your test date. On your test day, eat a good breakfast, drink a soda or something that will wake you up and prepare you. I always drink a soda because it's just, I don't know, it just give me energy. And bring your ID, social security card, and or debit/credit card, just to prevent you from being turned away or having to reschedule. Turn your phone off or leave it in the car. They let you put it in the locker, but nowadays, we have alarms and notifications coming on our phone, different alerts. So, what if you have like a public safety alert on your phone and it goes off, and now they are going to disqualify you or make you reschedule because your phone is disturbing people? Now you have to come from your test seat to turn it off, and they may think you're gonna look at your phone to cheat. They may think it's a code for, oh, they just came out so they can read a quick answer or something. You just never know. Use the restroom before your test. They do let you use it during your test as well, but you have to remember to raise your hand. You can't just get up or look around because they're going to think that you are cheating. So just raise your hand before you have to get up. Do not cheat or attempt to cheat. They do check your glasses. They check to make sure that you do not have a certain pen or watch that will make you cheat. So I would just remove all electronics, watches, everything. Just do not bring it in so they do not think that you are cheating. Raise your hand before getting out of your seat in the test area. Even after you are done with the test, just still raise your hand to let them know that you're done before you get up. A lot of this preparation you should remember from when you took your x-ray test, or you may have taken another registry and you know this. So put it in the comment box if you have another registry, or or this would be your second modality. All right, for your results, the preliminary results will be ready to view on the screen after you have taken the test. Make sure you remember to close all of the browser out, like the screen, to make sure that it's saved. Then we are not going to talk about what happens if you fail, because I know you all will pass on the first attempt. You all see, I have witnesses, at least 4 or 5 people who have already commented and told me that they did pass the test. So I would say click on my playlist and just let the playlist just play all the way through. Um, your results are going to be mailed to you as well. And congratulations for passing your mammography registry exam. All right, so that's it for the video. If you made it this far, I hope I gave you everything that you need to know to make sure that you are ready. Check out my Mammography Registry review playlist for the entire study guide lessons, review questions, answers, and explanations. And good luck. And then shout out to all of these ladies who passed their registry on the first try, I'm going to assume. They watched my videos, they ran through the playlist, and I also had a person, if they did check out my playlist, some people had requested that I made new videos or updated videos. So they did this whenever they say, oh, maybe I want more, or maybe I want a new video or updated video. And it's also helpful if you let me know when you're taking your test date. Sometimes I try to get new material out before someone test date, but sometimes I'm just not able to, because I work. I love making these videos for you all, but I'm not getting paid, anything. It's like when I make these videos, no one have given me any money. I'm just making this in my free time because this is just something I love to do. So that's why I always appreciate if someone thumbs up the video, even if you subscribe, even if you left a comment and just like, this video helped me, thank you so much, or I passed my registry. I enjoy when I see comments like that. But anyway, I hope I gave you everything that you need to pass your registry. And yeah, just click on my playlist and just let the video just play all the way through as many times as you need to. Share with your friends, share with anyone that you know who is studying for their test. All right, that's it. Thank you all for watching. If you enjoyed this video and found it helpful, could you please give it a thumbs up? Bye.